Hello, everyone. Today we're going to talk about the diagnosis and management of hyponatremia. We will follow an easy 9-step approach. This approach will help you diagnose and manage most cases of hyponatremia. So let's start by going through some facts. So hyponatremia and hypernatremia are not a sodium disorder. They are water disorder. So hyponatremia means too much water in the body that cannot be excreted. Hypernatremia, on the other hand, is too little water that has not been replaced. The term hyponatremia and hypernatremia might be confusing to a lot of you because it implies that there is a problem with the sodium, but that's not the case. Sodium disorders leads to volume depletion and volume overload or edema. So too much sodium causes edema or fluid overload, and too little sodium causes volume depletion. The clinical volume assessment is usually non-reliable, and studies show that only 50% of times the clinicians will agree on the findings. Another fact, the presence of edema does not mean that the direct cause of hyponatremia is volume overload. There is a very important term that you should get used to, and that's the effective arterial blood volume, EABV, because it's the key in determining the cause of hyponatremia. So what's the effective arterial blood volume? EABV is the portion of blood volume that's present in the arterial tree and filling it down to the capillaries to ensure good tissue perfusion. The kidneys will sense the effective arterial blood volume, and based on that volume, it will decide if the body is well perfused or not. Why is it important? Because you could find an edematous patient with volume overload. However, they might have low effective arterial blood volume. And the common example of that is heart failure patients, liver cirrhosis, and nephrotic syndrome. In these patients, there will be edema in the form of fluid accumulation in the interstitium, like, for example, the lower limbs. However, the effective arterial blood volume, the portion of blood in the arterial tree, of the arterial system, is depleted. Therefore, the kidneys will sense a low volume rather than an overload. Another fact about hyponatremia might have more than one cause in the same patient. A classical example is an HIV patient with hyponatremia due to SIADH, syndrome of inappropriate ADH, in addition to volume depletion and adrenal insufficiency. Urine osmolarity is the cornerstone test, and doing it will help you successfully diagnose and manage hyponatremia. Initiating treatment without sending a sample for urine osmolarity first can cause confusion of the clinical picture and a complicated puzzle that's difficult to decipher, and that might delay the correction of sodium. When we're talking about hyponatremia, we're really only interested in hypotonic hyponatremia. Why? Because this is the most dangerous type of hyponatremia, and it can lead to cerebral edema because of the low tonicity. Isotonic and hypertonic hyponatremia poses no risk to the patient. They don't cause cerebral edema. So let's go through the causes of hypertonic and isotonic hyponatremia. So intravenous mannitol, IVIGs, surgical irrigants like glycine, sorbitol, or mannitol irrigation solutions that are used during TURP, hysteroscopy, or laparoscopic surgery. Pseudohyponatremia is one of the causes as well. What's the cause of pseudohyponatremia? It's an artifact due to sodium measurement lab technique, and we see it in lipemic serum, obstructive jaundice, and plasma cell dyscrasia. Okay, so we'll keep these facts in mind. And the most important one that I want you to always remember is the effective arterial blood volume. And as we said, effective arterial blood volume, or EABV, is the portion of blood volume that's present in the arterial system, or the arterial tree, down to its capillaries, and it's responsible for tissue perfusion. The kidneys will sense this volume as the reflection of adequacy of tissue perfusion. So if it's low, the kidneys will start acting. Okay, let's go through the approach. As we said, it's 9-step approach, simple and straightforward. First step, you have to correct the serum sodium to the glucose level. There is a formula, but nowadays we all have mobile phones, and there are a lot of calculators that you can use to make this calculation quickly. So you correct the sodium for the glucose. If the level of corrected sodium is normal, then that's it. There is no hyponatremia, and you stop there. But if the corrected sodium level is low, then you have to move to step 2. Step 2, measure the plasma osmolality. If it's normal, then it's not a hypotonic hyponatremia, so no further action is required at this juncture. But if the plasma osmolality is low, then you have to move to step 3. Step 3, measure random urine osmolality and send for urine sodium and urine potassium. Step number 4, the patient has severe symptoms of hyponatremia, symptoms like seizures, coma, or respiratory arrest. Vomiting is also one of the symptoms of severity. If yes, then you have to start treatment immediately with 3% saline infusion. There are different guidelines in this regard. There is the American guidelines and the European guidelines. It doesn't matter which one you follow. So you can give 100 ml bolus of 3% saline, and it can be repeated twice more as long as the symptoms persist. And the serum sodium has to be monitored hourly until you achieve a rise of 5 points, or 5 millimole per liter. So if you raised the sodium level by 5 points and the patient is still symptomatic or having seizures, then it's unlikely for the hyponatremia to be the cause. However, a lot of people will go for raising another 5 points, so 10 points in total, before attributing the neurological features to another diagnosis. So, step 4, symptomatic patient, you have to act quickly and start hypertonic saline. But if the patient is asymptomatic, then you have to move to step 5. And by the way, like after managing the symptomatic patient, you have to move to step 5 anyway, because you need to ascertain the diagnosis to help you in further management. So step 5, what do? You check your urine osmolality result. The urine osmolality tells you if the ADH is acting or not. Okay, so this will determine how you manage the hyponatremia. So if the urine osmolality is less than 100, then there is no ADH action. Okay, and the causes in this case are primary polydipsia, beer hypotomania, Tianto syndrome, excessive use, etc. And in these cases, the treatment is fluid restriction, and then you treat the primary cause. If someone is using ecstasy, then they have to stop. If they have primary polydipsia, you need to get the psychiatry team involved, and so on. So if there is no ADH acting, then it's just fluid restriction. And of course, monitoring of the serum sodium level. What would you do if urine osmolality is 100 or more? So in that case, ADH is in action. So you move to step 6. The question will be, is this ADH acting appropriately or inappropriately? When does the ADH act appropriately? It acts appropriately when there is low effective arterial blood volume. If it's acting inappropriately, then it's a syndrome of inappropriate ADH or SIADH. Okay, let's go through the role of ADH in volume management. So as you know, ADH is also called vasopressin. Its main action is reducing or stopping the excretion of free water. But it also has another action, which is vasoconstriction. So what happens when the effective arterial blood volume is low? The RAS system will be activated. The renin, angiotensin, aldosterone system will be activated. And several physiological changes will start happening. However, when the volume loss is more than 10 to 15%, the RAS system will call for the ADH to help them. The ADH will be secreted to help by causing vasoconstriction, hoping for an increase in blood pressure and tissue perfusion. However, ADH cannot do the action of vasoconstriction independent of its action of free water retention. So yeah, it came out for help, but as a side effect, free water retention will happen. And when free water is not excreted, hyponatremia will happen. Okay? As you can see, the problem here is merely a water problem. It's not a sodium problem. A common example that I use while teaching doctors about hyponatremia is the glasses example. So if we have 3 glasses, each glass has 1 gram of salt, and we fill the first glass to its quarter with water, the second glass to its half, and the third glass fully filled with water. And then we tasted each glass. The one which is filled until its quarter with water will taste salty, while the one that is fully filled will taste mainly water with a faint taste of salt, while the glass that's filled until its middle with water will feel balanced. You'll get a balanced taste of salt. So that's exactly what happens in water disorders. The fully filled glass is hyponatremia. The glass filled until its quarter is hypernatremia, and the middle one represent the balanced sodium level. So as you can see, the salt is equal in all glasses, but the taste is different depending on the water presence. So hyponatremia is too much water that you cannot excrete, and hypernatremia is merely dehydration. Okay, clear? So let's go back, step 6. So we measure the urine osmolality. If it's less than 100, there's no ADH. More than 100, ADH is acting. We'll ask ourselves, is it an appropriate action or not? Okay. So you have to ask yourself if there is any heart failure or liver cirrhosis. If there is heart failure or liver cirrhosis, then it's usually it's a vicious circle. These patients will have the fluids moving out of the vasculature to the interstitium all the time. Okay, the splanchnic pooling of blood and liver cirrhosis, and the reduced cardiac output in heart failure will divert salt and water out of the vasculature to the interstitium. Thereby, the effective arterial blood volume will be low. And it's very difficult to treat without improving the heart function or improving the liver function. So you treat just as usual. You treat the heart failure and you fluid restrict and can use diuretics. Same for the liver cirrhosis. Generally speaking, the prognosis is poor when there is persistent hyponatremia in these patients. Some people use Vaptans in heart failure. So, if no heart failure or liver cirrhosis, then you have to move to step 7. Step 7 is urine sodium less than 25. Like some labs will give you a value of less than 10, some of them will give you less than 20, less than 25. So it doesn't matter really. You can use your lab reference or you can use a 25 as a cutoff. Just keep in mind that urine sodium is not reliable if patients is on diuretics, because the diuretics will increase the sodium excretion in the urine, and this will increase the urine sodium regardless of what's going on with the hyponatremia. Also in patients with heart failure and patients with liver cirrhosis, because the effective arterial blood volume is always low, the urine sodium might always be less than 25, regardless of the cause of hyponatremia. So in these patients, I don't use the urine sodium to guide me in the diagnosis or management. Okay, so if the patient is not on diuretics and doesn't have significant heart failure or liver cirrhosis, then you ask yourself, is it less than 25? If yes, then the ADH is acting appropriately due to volume depletion or precisely effective arterial blood volume reduction. Of course, you have to do your clinical examination. You have to look for signs of volume depletion. And let's go quickly through these signs. So when volume depletion or effective arterial blood volume first start to reduce, the patient will start to have orthostatic tachycardia. The next stage will be orthostatic hypotension, and then resting tachycardia. And when the volume depletion is severe, the patient will be hypotensive. So, if urine sodium is less than 25, replace the volume with normal saline. The patient lost blood, you give them blood, and so on. You'll monitor your serum sodium and urine osmolarity every 2 to 3 hours. And this usually depends on how severe is the hyponatremia. Any hyponatremia less than 125 is considered to be severe. If ADH is acting appropriately, then this is the most dangerous type of hyponatremia if it's chronic. Why? Because as soon as you replace the volume, you'll switch off the ADH and its action will be abolished. And what happens? The body will start excreting the excess water, and patient will become polyuric. This can lead to a rapid rise in sodium level, and it increases the risk of central pontine myelonolysis. So in these cases, with appropriate ADH action, the monitoring should be very close. The urine output should be monitored as well. If the output is 150 ml or more in 2 consecutive hours, then you have to think seriously about starting desmopressin or DDAVP to slow down the water loss, and you tailor it according to your time block. When did the hyponatremia first started, and your rate of correction. Usually we don't go for more than 18 millimole per liter correction in 48 hours. Now, what would you do if urine sodium is more or equal to 25? You'll move to step 8. So step 8, is there clinical evidence of volume depletion? As I mentioned, orthostatic tachycardia, orthostatic hypotension, low blood pressure. If yes, then you have to consider primary adrenal insufficiency. And another diagnosis will be cerebral salt wasting. This is usually a polyuric patient with intracranial surgery or pathology. In these patients, you give intravenous normal saline, and you investigate and manage accordingly. Just a note about cerebral salt wasting. Someone smart might say, okay, how would salt wasting cause hyponatremia? And we know that hyponatremia is not a salt disorder. So in cerebral salt wasting, the patient is polyuric, excreting a lot of salt, a lot of sodium. As we know, sodium is accompanied by water, okay? So they are losing isotonic fluid, which is salt and water. This will lead to reduction in effective arterial blood volume, and subsequently the activation of the renin-angiotensin-aldosterone system, and then ADH secretion to act as a vasoconstrictor. And of course, as a side effect, as we said earlier, the free water will be retained, okay? So in cerebral salt wasting, the wasting of salt is not the cause of hyponatremia. The wasting of salt is a cause for effective arterial blood volume reduction and ADH secretion, which retains water and causes hyponatremia, okay? So you have to break this cycle by giving IV normal saline to restore the volume and to switch off the ADH secretion. The urine sodium is more than 25. Why? Because in cerebral salt wasting, there's salt coming out in the urine. So it's expected for the urine sodium to be more than 25. Now, if the urine sodium is more than 25 and there is no evidence of clinical volume depletion and there is no suspicion of effective arterial blood volume reduction, then you move to step 9. Step 9, the diagnosis will be syndrome of inappropriate ADH secretion. Because if you don't have effective arterial blood volume reduction, then the ADH is acting, okay, then it's acting inappropriately, okay? And you diagnose the SI ADH. So what do you do for these patients? You fluid restrict them. But the question is fluid restriction alone enough? You have to calculate your free water clearance to determine that, okay? How do you calculate it? It's 24 urine output multiplied by 1 minus urine sodium plus urine potassium divided by serum sodium. You can reduce this equation to the following. You add the urine sodium and urine potassium together. If the sum of this equation, okay, addition of the urine sodium and urine potassium together, if it's greater than the serum sodium level, then you can never ever correct SIDH hyponatremia with free water restriction alone or with fluid restriction alone. Even if you kept the patient MPO, it will not correct, okay? Because it's a negative equation, okay? So what do you do in that case? You add sodium chloride pills to encourage the excretion of sodium accompanied by water, by the excess water in the kidneys. You can also use furosemide, and you can use urea powder or urea pills if it's available in your center, okay? So these are the 9 steps to approach and manage hyponatremia. Now, these steps are just to organize your thinking and your approach, but in real life scenarios, you won't send for urine osmolality and then send for serum osmolality. They are all sent together. As soon as the patient presents to the emergency room and they find that sodium level is low, they should send all the workup, the urine osmolality, urine sodium, and urine potassium, and the plasma osmolality, okay? And when you first go see the patient, of course, you're going to assess them clinically. You won't start by the results. You will start by clinical examination. And during clinical examination, you look for acute neurological signs. You'll ask about symptoms. You'll be worried if there is vomiting. And you will do a clinical assessment to see if there is any evidence of volume depletion, heart failure, liver cirrhosis, etc. Okay? So this 9-step approach is a way to organize your thoughts while approaching these patients, okay? But again, I can't emphasize enough the importance of clinical assessment of the patient as soon as you see them, okay? So that's all about step approach for hyponatremia. I hope you find it useful, and please feel free to comment on this presentation and ask any questions. Thank you.